This is my topic for today. Lumbar ASD is the biggest challenge and a burning topic considering the ever-increasing number of spinal fusion surgeries. There has been increasing interest in learning MIS techniques, as you can see. Surprisingly, incorporation of the MIS techniques for treatment of ASD is hardly discussed. So this is a descriptive study to manage lumbar ASD effectively using MIS techniques. This study describes various step-by-step techniques of managing lumbar ASD using MIS techniques in patients who have undergone either previous open or spinal fusion surgeries. All the surgeries were done by a single senior surgeon from Jan 2008 to December 2023. The surgical techniques were devised based on the duration of ASD since primary surgery, the fusion status of the operative level, and technical difficulties encountered. So let us discuss the first technique, which involves implant removal at the primary level and MIS TLIF at the ASD level. As you can see, this is a primary fuse segment. Patient develops adjacent segment disease. So using paraspinal incisions, implant removal was done. Guide wires were inserted in the adjacent segment. Using tubes, MIS TLIF was done at the adjacent segment. Cage was inserted with bone graft. Screws were inserted over guide wires and connecting rods were applied. So let us discuss a case done by using the above technique. This is a case of a 76-year-old male who underwent posterolateral fusion 14 years back, now presents with bilateral lower limb radiating pain of 8 months duration. As you can see on the MRI, a diagnosis of L3, L4 ASD was made. So plan was to do the implant removal at L4, L5, which was the primary level, and do MIS TLIF at L3, L4. These are the intraoperative image where you can see first the implant removal was done, then by using percutaneous incision, guide wires were inserted into adjacent segment and MIS TLIF was done. This is the final image of the same patient. Let us discuss the second technique, which involves MIS TLIF at the ASD level while keeping the fuse segment silent. So this is a patient with primary fuse segment. There is a confirmed fusion at the primary level. Patient develops adjacent segment disease. Now the connecting rods were removed. The proximal screws were removed. Guide wire was inserted at the adjacent segment. Using tubes, MIS TLIF was done at the adjacent level. Screws were inserted. Connecting rods were applied while keeping the distal screws silent. Let us discuss a case done by the above technique. This is a case of a 42-year-old male who underwent L5S1 TLIF 15 years back, now presents with right lower limb radicular pain of 1 year duration. As you can see on the lower image, the L5S1, which was operated previously, has a patent canal, while the patients develop L4, L5 stenosis and listhesis. So the CT scan shows the confirmed fusion at L5S1 level, which was primarily treated. So a diagnosis of L4, L5 ASD was made. Plan is to do MIS TLIF at L4, L5 by keeping the S1 screws silent. This is the final image of the same patient. Let us discuss the third technique, which involves the extension of fusion to the adjacent segment, including the primary level in the construct. This is a primary fuse segment. Patient develops adjacent segment disease. By using paraspinal incision, implant removal was done. Guide wires were inserted into adjacent segment as well as the primary segment. Using tubes, MIS TLIF was at the adjacent segment. Screws were inserted over the guide wires and connecting rods were applied, including the primary level in the construct. So this is a case of 77-year-old male who underwent L4, L5 TLIF 2 years back, now presents with lower limb radiating pains of 2 months duration. As you can see on the MRI, a diagnosis of L3, L4 ASD is made. Plan is to do the extension of fusion to L3, L4, including the previous level in the construct. So this is the intraoperative image showing first the implant removal was done. Then by using percutaneous guide wires, which was inserted into both primary level and adjacent level, here we got an opportunity to medialize the previous right S1 screw, which was neutral. Then by using tubes, MIS TLIF was done at the adjacent segment and connecting rods were applied, including the primary level in the construct. This is a post-operative X-ray of the same patient. As you can see, some out of degenerative scoli also got corrected. This is a preoperative scar with such a big incision used to do one level open TLIF. While on the right side, you can see two paraspinal scars which are half of the length used to do 2 level MIS TLIF. That's the beauty of MIS. So let us discuss the fourth technique, which involves bypassing the primary fusion level and doing MIS TLIF at ASD level above and below. This is a primary fuse segment. Patient develops ASD proximally as well as distally. Guide wires are inserted at both the adjacent segment level. Using tubes, MIS TLIF was done at both proximal as well as distal ASD level. Screws were inserted over guide wires and connecting rods were applied, bypassing the primary fusion level. So this is an 80-year-old female, an operated case of L4, L5 MIS TLIF 6 years ago. Patient presents with right buttock pain and claudication pains of 3 months duration. A diagnosis of L3, L4, which is proximal, and L5, X1, which is distal ASD was made. Plan was to do extension of fusion at both the levels, bypassing the primary level. As you can see in the middle image, which is L4, L5, is a primary treated level which has a patent canal, while L3, L4 and L5 also undergo degeneration, that is both proximal as well as distal ASD. Percutaneous guide wires were inserted into proximal as well as distal ASD level. Using tubes, MIS delivery was done at both the levels and connecting rods were applied, bypassing the primary level. This is the final image of the same patient. So, 8 patients were successfully treated by above technique. None of them had to be converted to open surgery. So, as you all know, the advantages of MIS is known to everyone present here. All these advantages were incorporated in the above technique. So let us discuss the first technique, which involves implant removal at the primary level and MS relief at ASD level. The indication of this technique becomes when there is a confirmed fusion at primary level, no revision required at the primary level, and the implant removal is feasible. The advantage is that a single incision can be used for implant removal, decompression and fusion. Technique 2, which is MIS relief at ASD level while keeping the fused segment silent. It is done in cases where you have confirmed fusion at the primary level and there is technical difficulties in the implant removal. At many times there are different companies or patients who have treated to come to us. So the screwdrivers lack uniformity, making screw removal difficult. Applying excess axial stress while removing the screw with an ill-fitting screwdriver or plier can cause breakage of the bony ridges and can cause microfractures. This is all can be avoided by bypassing it. Hence, this is a time-saving procedure and can be used for morbid patients. Technique 3, which involves extension of fusion to adjacent segment, including the primary level in the construct. It is indicated when you have a doubtful fusion at the primary level. Any sort of revision required at the primary level, like how we got an opportunity to medialize one screw, and then ASD associated with some degree of deformity. So technique 4, which involves bypassing the fusion level and doing MIS relief at proximal as well as distal level. It is done in cases where patient have both proximal as well as distal ASD. It is done in patient who is average irregular fat. Advantages, it reduces operative time and risk associated with prolonged surgery. It avoids crowding of implants as seen in case with rod-to-rod connectors or comminuous dominoes. The only disadvantage is that wound closure and implant prominence may become an issue in a thin-built patient. There are tons of literature available to manage ASD with open techniques. But what about MIS? There is significant vacuum in the literature in terms of managing ASD with posterior MIS techniques. The author thus offers innovative and successful MIS techniques for managing ASD in lumbar spine. Thank you.